They joke about interventional cardiologists and they say, if you want to fix a lesion, you do an IVUS, so you can make money. If you don't want to fix it, you do an FFR, because most of the time it comes back negative. So it depends on which team you are with. So I have to say I do more IFRs and FFRs than we do IVUS for many reasons. I have a lot of slides, so I'm going to try to go through them quickly to show lesions by IVUS. So this is the outline. We're going to, at the end, talk a little bit about OCT. I thought it's not going to be complete without talking about OCT, which is the new modality in imaging the coronaries. What you see is not always what you get. Sometimes what we see can be a shadow of something else. And this is why. So we need to get the whole picture. And this is what we get by angiogram. Angiogram is a luminogram where we look at inside the lumen of the blood vessel. And this depends on the angle we look at it. So if you have somebody with an eccentric lesion like this one, if you look at it this way, you're going to have a tight lesion. If you look at it from this side, it's going to be normal. Or if you have a complex lesion, you cannot really quantify using angiography. This is why we came up with imaging of the inside of these blood vessels using IVUS, which is like a 3D picture for the angiograms. We use IVUSs and we're going to talk about these frequencies, between 20 to 40 megahertz, which is more resolution. We all know that megahertz from echocardiography. The regular probe is about 2, the TE is 5 megahertz, so we get more resolution. So the more frequency we get, the more resolution we get, but that will lead to less penetration, because with more frequency you have smaller wavelengths. Smaller wavelengths give you better resolution, but you cannot penetrate more. So that leads to less penetration. We're going to talk about in a minute here. In IVUS, we can see things as small as 100 to 200 microns. OCT, we can see things as small as 10 to 20 microns, because OCT uses light, which is much, much more frequency than what we get with ultrasound. And this is why we have a very good resolution, but on the other hand, we have very, very less penetration. We can see outside the inner wall of the blood vessel. There are two systems of IVUS in the market. The first one, the phased array system, where there is small crystals placed around the catheter, and they emit ultrasound and they receive ultrasound. It's used a 20 megahertz system. It has a deeper penetration, less resolution than the other system. It is non-rotational. We can use the chromaflow and virtual histology with this system. This is the volcano system, which is, I think, this is the most common system used, and this is the one we use in Jordan University. The other system, which is the rotational system, where the single crystal is there and it rotates at 1800 RPM, and it goes very fast and gives you better resolution, but on the other hand has its own issues. One of the issues we have with that, because it's rotational, it vibrates. You see much more spasm with this system than what you see with this system, and there is certain artifact that you see with this one, you don't see with this one. We're going to talk about it. This is the example of this one, is the Boston Scientific system. Okay, the IVUS system, we can introduce the wire and then the IVUS ultrasound over through a minimum of 5 French system. We can use a 5 French guide. We'll take an IVUS catheter over a 014 wire. We have to anticoagulate a patient using usually heparin. And if we use the rotational system, I would recommend that we use nitroglycerin. Or if we are IVUSing small or medium-sized vessels, because of the risk of spasm, I would recommend that we give nitroglycerin before we do the imaging. IVUS is very safe. Its main complications is spasm. We see that in 2.9% of these cases. Other complications include dissection, and acute MI is very low, like 3 in 1,000 or so. Major complications are very, very rare to happen. We use IVUS to see the lesion morphology. Calcium, there's a lot of data on calcium. plaque characteristics, dissection, thrombus, and all that stuff. We use IVUS to optimize PCI. We measure the vessel size and length. We image stents and see what are they, we're going to talk about in detail now. Evaluate complications, dissection, thrombus. And there's a role of IVUS use in left main, much more than we use in non-left main lesions. Anatomy. This is a picture of the blood vessel. This is the lumen of the blood vessel. This is the intima. And this is definitely a very abnormal intima because it's very, very bright and very thickened. Usually it's a thin paper intima. The black we see here is the media, which is made of smooth muscles. Which is dark and does not reflect ultrasound. And then we have the adventitia, which is outside of the wall here, and we call that the EEM. So this is a picture of a normal ultrasound blood vessel. As we can see, the intima is very thin. The black layer is the media, and the outside is the intima or the EEM layer of the blood vessel. This is obviously diseased vessel. This is the catheter we have. This is the intima from here. This is very thickened intima. This is the media here. You can see there is a plaque here, maybe a small calcification in this area, very, very rich plaque here, fibrofatty plaque here. There is more here, soft plaque. We can see the lumen is more radiolucent than the other one. I'm going to start with measurements of the IVUS. We measure usually the EEM area, which is the junction between the media and the adventitia, which using this one here. This is the external elastic membrane, which is the total size of the blood vessel we have. We can also measure the lumen area, which is the inside lumen of the blood vessel. This is where the blood flow is there. And we also can do the maximum and the minimum diameters of the blood vessel. So we can see how much diameter we have inside. We can do calculations. We can do lumen area stenosis, where we take the reference lumen cross-sectional area, and we take out of that the minimum lumen cross-sectional area, divide that by reference lumen area and multiply by 100. We get what we call the lumen area stenosis. This is how much stenosis we have in the area of interest we are looking at. We also can do lesion atheroma area, which is the area between the red and the blue. This is the area between the red and the blue. This is how much atheroma we have in that area. So we measure both areas and subtract them from each other, and we get what we call lesion atheroma area. It's also called the plaque burden percentage, which is the lesion atheroma area we have here, and we divide that by the big area we have, the big area inside the EEM, multiply by the 100, we get the plaque burden percentage. Then if we do a motorized pullback for our ultrasound, there is a motorized device. You can put your IVUS device, and it's going to be motorized usually at a speed of 0.5 millimeter per second. And then because it's motorized, then we can get the total area over a certain period of time, and then we can get the volume of the atheroma in that segment. This is more a research tool than a clinical tool for us. This is an example here. We look at the reference area. We go for the lumen, for the normal reference area, proximal and distal to the lesion. And usually we'll go with the bigger one as a reference area. And most of the time it's going to be the proximal one rather than the distal one. So and this is the area of interest. We can see this is the lumen here. And there's a huge soft plaque. This is called plaque and media. And this is the lumen area here, and then we can do all the calculations we did before. For example, lumen area stenosis is going to be the cross-sectional area in the reference area minus the lumen area here divided by this one, gives you the percent stenosis. The plaque burden, you can take the big elastic area here minus the lumen area, going to give you the plaque percentage area. Calcium. Calcium is a major problem we have in the cath lab. If you ask me what's the worst lesion to work on, is the heavily calcified lesions, because they do not respond to anything we do, and we have to do more things for them. So calcium presents in the IVUS as a very bright echo, brighter than the adventitia, very bright, and there's acoustic shadowing from plaque, meaning that we can't see the area behind the calcium. This is a calcium. This is a 360 degrees calcium, and behind this calcium, I can't see anything. So we are blind behind that area, and even sometimes we can get reverberation artifacts from calcium. Then calcium, we need to quantify calcium by the degree, the arc, how much calcium we have. Is it 80 degrees, 180 degrees, 270, or 360, like the example we did before? And that has to do with us before we do angioplasty and put stents. We need to know we need to modify our lesion. If we have somebody with 360 degrees calcium or more than 180 degrees calcium, I cannot just go ahead and put direct stenting for that one. I have to pre-modify that lesion and take care of it. And if you have more than 180 degrees of calcium, you're probably going to end up needing either cutting balloons, and sometimes you need to do for them rota ablation to modify the lesion before you can put a stent. Because the risk if you put a stent in a heavily calcified lesion, you may not be able to expand that stent and you get stuck with it. And you can take bigger and bigger balloons and you're not going to be able to expand it, especially if it's 360 degrees calcification. And we can also quantify calcium as a superficial, very close to the catheter, or very deep, more in the media and the adventitia. This is the most common plaque we see, the fibrotic plaque. This is fibrotic plaque, a dense area in the wall. This is the lumen, and this is the plaque in that area. Sometimes this plaque is very thick to the point that we can cause some shadowing, but usually I would say there is some calcification involved with these fibrotic plaque, which are the most common plaques we have. This is a more example of a soft plaque. This is the area here. It's a soft plaque. It's not as dense as the other one. It's less dense than the adventitia. And sometimes you can see in these plaques, as we can see in other images, you can see a lipid pool area, which is much more hypodense areas inside these plaques. IVUS used for stent placement. There is no rule for routine use. We don't need to use IVUS for every case or every one we do. Maybe it's helpful in large vessels because that can help us size our stents. You generally recommend it for left main PCI interventions. I'm going to show the data about that. IVUS can help us size our stents and the length of our stents if we use a motorized system. IVUS can help us if we have any PCI complications, looking for dissection, thrombosis, stent expansion, and if we have a missed lesion, especially in the ostium, and stent fracture. And there's also data about using IVUS and patients coming back with stent thrombosis to find out the reason for their stent thrombosis. Stent size and length. Usually we go to the reference vessel, either proximal or distal, as I said, and we need to avoid the remodeling area because that can be either positive or negative remodeling, going to change the size. The other problem with IVUS, if it is not parallel to the wall, we can get a bigger size or ovoid shaped vessel, and that can overestimate the diameter. So with IVUS, you can always oversize, but it's very hard to undersize unless you go to an area of negative remodeling in the reference area. There are two terms when we come to stent and IVUS. There is a malapposition and underexpansion. Malapposition, stent does not contact the vessel wall. Underexpansion, stent is not at a nominal diameter, was not fully deployed at the nominal diameter, and we always recommend for our fellows to go even higher than the nominal diameter to make sure that your stent is fully expanded. Examples. This is a well-opposed stent, especially in this one here. This is one very, very well opposed, but I would say maybe it's a little bit undersized, but it's really touching the wall and it's doing really well. How do we know this is a stent? You can see these struts, the interrupted struts, like a wheel going around here. This is a very well opposed struts for the stent. On the other hand, this is a malopposed stent. We can see these are the struts of the stents here, but on the other hand, there's an equilucent space behind this one. This stent is malopposed. It's not fully expanded that to the wall of the vessel there. It's either not fully expanded or it's undersized, and this stent needs to be post-dilated. Otherwise, there is a risk of complications, especially stent thrombosis here. In-stent stenosis. IVUS can give us the whole story about in-stent stenosis. As we can see, these are the struts of the stent here, and you can see there's a thick area between the lumen and the struts of the stent. This is intimal hyperplasia. This patient has a severe intimal hyperplasia. This one here, we can see the two layers of stenting in this vessel, in this area here. And there's a small intimal hyperplasia here. There's a much less intimal hyperplasia here. So it can give us the story about the instant stenosis and how much intimal hyperplasia. I have more slides at the end to show the same thing. IVUS used for stent thrombosis. It is generally recommended if you have somebody with a stent thrombosis, either you do for them IVUS or OCT. After you do initial aspiration and PTCA and restoring blood flow before you deploy a second stent to see what's the possible mechanism of your stent thrombosis. The possible things could be under expansion, protrusion of tissue through the struts inside the lumen, edge dissection extending inside the stent, and malapposition. And there is a data saying it is not as critical as the other three reasons. This came out from the Horizon trial, where they looked at all their patients who came back with stent thrombosis, and they found that if you have the cross-sectional area of the stent is less than 5 millimeters square, or they have a protrusion or dissection, it is statistically significant, increasing the risk of stent thrombosis. Malapposition was not statistically significant risk for a stent thrombosis. Vulnerable plaque. Again, this is the catheter we use. This is the lumen, and this is a plaque. We can see the plaque as we move in, and we can see this plaque has the radiolucent areas in it, and this is a lipid core, and we can see that the cap on top of this lipid core is very thin. With IVUS, we cannot measure the cap here, but we will be able to measure that by OCT, and I do have an example of that. If we see this plaque in this patient needs to have an aggressive treatment for vulnerable plaque that can potentially lead to an event later on. Features of vulnerable plaque: thin cap fibroatheroma, TICFA, which is less than 65 microns, which we, as I said, we can't measure that by IVUS, but we will be able to measure that by OCT. If we have a minimal luminal area less than 4 millimeters square, the plaque burden more than 70%, which we calculated before, or if we have somebody with positive remodeling, with a remodeling index of more than 1.05, meaning it's more than 5% of the reference vessel. This came in from this trial, the Prospect trial, where they looked at, they used virtual histology. We're going to talk about it also today. And in this study, the ACS plaques, they found that if you have TECFA, you have more risk of ACS. If you add lumen area less than 4, if you have a plaque burden more than 70%, if you have all of them, you are more likely to have the unstable plaque and event. Modeling, positive or negative remodeling. If the blood vessel is expanding, like this one, this is called positive remodeling. If your blood vessel is shrinking, on the other hand, this is a negative remodeling. This is more unstable, and this is more risky, more chance of breaking later on and give you an acute event. This is more stable plaque and less risk of rupturing down the road. This is an example. How do we do the remodeling index? We go to a reference area, and in the reference area we measure the EEM area, and we go to the lesion area and we measure the area, the EM area. This one was 18.9, 14.9. If you divide this by this one, is going to be more than 1.05. This is a positive remodeling. This one, the area of the lesion is 11.5, or the reference one is 16.0. This is negative remodeling. This is more stable plaque than this plaque we see here. Left main evaluation. This we're in a crossroads now with Dr. Ramzi here about left main evaluation. This is a famous study from Mayo Clinic where they looked at the people in Minnesota and in 121 subjects, and they did IVUS for normal people, and this is a normal distribution, and they took 2 standard deviation, and they came up with a number of 7.5 millimeters square, and they said anybody below 7.5 is more than 2 standard deviation away from the mean, and that's not normal. And this is where we came up with this number of 7.5 millimeters square. They use this one to use clinical outcomes. If you have an area of less than 7.5 millimeter left main and you did not get revascularization, you have the worst outcome over 7 years. So this is in 214 patients with a significant p-value. Then we had studies correlating IVUS with FFR for left main. This is in a 55 patients where we did the minimal lumen area and FFR for these patients. And when we took the cut point of 0.75 by FFR, and then the minimal luminal area, we came up with 5.9 millimeters square, which is 6 millimeters, which is the other number we use for left main IVUS significance. So in QCA, IVUS versus QCA in left main, I thought this slide can be helpful for us in one thing. If we look at everybody, there's correlation here, but there's correlation at the mid-segment of the left main. The ostium, there is no correlation. The distal, there's correlation, meaning that ostial lesions in the left main is very, very hard to assess by angiography. And those are the lesions you're probably going to need more help, such as an IVUS, to look at your ostium, because there's not much correlation between IVUS and QCA, especially in the ostial lesions of the left main. What are the guidelines say about left main IVUS? The left main artery stenosis, a minimum lumen area of 2.8 millimeter or an area of less than 6 millimeters square, suggests a physiologically significant lesion for which patient may benefit from revascularization. If you have an area more than 7.5, suggests that the revascularization may be safely deferred and left alone. If you have an area between 6 and 7.5 millimeters square, you may require further evaluation, such as an FFR or an IFR in these patients. What about using IVUS in non-left main lesions, LAD, RCA, left circumflex vessel? This is the data looking at that. And comparing FFR with non-left main lesions, there is no good correlation. As the 0.75 FFR comes between 2.1 and 4.4 millimeters square. The common value we use in our practice is 3 millimeters square area. Less than that indicate hemodynamically significant using IVUS. But again, it is not, it is more than 80% sensitive, but it's only less than 50% specific, meaning it is not a great tool to assess non-left main lesions. This is why FFR or IFR, not IVUS, should be used in non-left main to assess hemodynamic compromise and significance for lesions we see. This is from the guidelines. There is no class 1 indication for IVUS. There is absolutely no class 1 indication. IVUS is reasonable for the assessment of angiographically indeterminate left main disease. IVUS is a good tool to assess transplant heart for transplant vasculopathy. And is reasonable to do to determine the mechanism of stenosis. It's reasonable, but it's a class 2B, meaning it's really have very, very not really a good tool to do for non-left main blood vessels. Okay, I'm gonna move on. This is virtual histology, where available by Volcano, where the tissue in the plaque was given different colors. Green for fibrous, red for necrotic core, fibrofatty in the less green, and dense one is a calcium. And so we can quantify our plaques. For example, this is plaque has a lot of fibrous tissue and necrotic core. The more necrotic core you have, the more vulnerable is the plaque, and the more likely that plaque can rupture and give you an event. Okay, this is where the data comes from. Again, this is a very soft plaque. We have very little necrotic core in this plaque, and very soft. This is a fibrous plaque in this patient with no calcium deposit by this. Okay, I'm gonna go quickly about some artifacts. This is a blood speckle here because there is a stasis. This happens if there is a slow flow, or if your catheter is obstructing flow and you're not having good flow. To get rid of that, you give some flush, normal saline flush. You clean that up, and you can see the lumen of the blood vessel. This is called NERD, and this is only seen in the mechanical systems because this system has to rotate. If there's a kink in the system or there's a tortuous vessel, we can have a missing area, and happens again in the mechanical Boston Scientific system, or if you have a small lumen, because the rotation will not be smooth. Ring down, this is mainly seen with the volcano system, where you have a halo, white halo around the catheter, and you can avoid that when you get the catheter to the tip of the guiding catheter. You push down and ring down, so almost like normalizing that area and getting rid of that artifact. Few words about OCT. OCT uses infrared light. It is much higher frequency. So what does that mean? Much higher frequency means more resolution, but very less penetration. So we see only the inner side of the wall. We can see what's behind the wall because of that. It uses about 2.7 French system, rotational catheter with automatic pullback. Advantage, resolution is excellent. We can see things as 10 to 15 micron. We can do that. With IVUS, it's at 100 to 200 microns. We can see the details of this one. Better near field, we can see the cap, stent, thrombus, and dissection. Beautiful pictures we can see. And it does penetrate calcium because it's light. Disadvantage, much less tissue penetration. We can see only 1 to 3 millimeters, but IVUS we can go up to 8 millimeters. We are unable to measure plaque burden because we can't see what's behind the wall, what's behind the plaque, and we cannot assess remodeling. The major disadvantage for OCT, which I believe is one reason why it's not taken off very well, it requires injection of contrast. With every time you're going to run an OCT, you have to inject about 8 cc's of contrast, and this is going to add up. You're going to do 3, 4, 5 runs. That's going to add 40, 50 cc's of contrast, and that's going to be an issue. And again, it has very limited use in left main because it's very hard to clean the left main from blood vessels. The reason we give contrast with OCT, because the blood vessels, the RBCs, reflect the infrared light. So we have to clear them up, to clear up the system so you can see the pictures. And it's very, very hard to give enough contrast to clear up the red blood cells from the left main. So it has very limited use. I think these are the two main reasons why the OCT technology, when it came out, we thought it was going to take over IVUS and throw IVUS away, but that didn't happen. This is a normal picture with the OCT. This is the catheter we have. This is guide wire shadow there. It's nice. You can see the lumen of the vessel very clearly, the wall very clearly, but we don't see anything behind. We don't see anything what's going on behind the vessel wall. Again, this is an example of lipid-rich core. We have it here, but we can't see it because we can see only the lumen of the blood vessels. We think it's there, a lipid-rich core. This is where we can measure the fibrous cap. We zoom in these areas. This was measured to be 40 microns. This was measured to 100 microns. And the TICFA is anything less than 65. So this is a very thin cap, and we can measure that easily with the OCT. Stent malposition. Very clearly we can see that the stent struts is away from the blood vessel here, and this is malposition. Very nicely seen, beautiful pictures. This is an example of possible mechanisms of stent thrombosis by OCT. There is in this area there is an edge dissection there, and this edge dissection can sometimes extend to the stent area and increase the risk of having stent thrombosis. There is a protrusion here inside. There's a protrusion here inside the struts. This should be like this circle. There's a protrusion here that's increases risk of thrombosis, and here there is malapposition as mechanism of stent thrombosis. This is a quick summary and discussion of the IVUS system we have. The Volcano, the Eagle Eye system, it's a phase array. There is nothing rotating. It's about 3 French system. We can do all of them through a 5 French guiding catheter. 20 megahertz. It can penetrate up to 10 millimeters. This is better penetration because it has a lower frequency, but has less resolution. And as look at here, this is much more frequency, and penetration is very poor, but the resolution is excellent in this one. Okay. Suggestion, where do we use each one of them? IVUS is good to assess plaque burden. If we're going to assess significance of non-left main disease, we use an FFR. If you're going to assess significance of left main disease, the primary modality is going to be an FFR. IVUS can be a secondary one. We need to be extra careful doing FFR for the left main, especially osteal lesions. Those osteal lesions, FFR, you should normalize your FFR catheter before you engage it. You don't engage your catheter. You get your FFR wire outside the catheter. You normalize. You pull your wire back, and then you engage in the left main. Because if you're assessing osteal left main, you can't do that in the regular way. To determine culprit lesion, we use IVUS or ACT. We cannot assess vulnerable plaque using FFR. We can't see the plaque itself. Diameter, IVUS is still the best way to go with that. Assessing stent expansion, malapposition, we can go with either IVUS or ACT. Etiology of stent thrombosis, I show you good pictures with OCT, but still IVUS is a good tool to do with these patients. Thank you.